All right. Good evening, everyone. A very warm welcome to all of you to GynoScope Session 3. We're delighted to have you join us for another insightful session in this academic series that offers a closer look, just like a telescope, into the field of obstetrics and gynecology. Today's session is centered on recurrent pregnancy loss. We are honored to have with us Dr. Aditya Nimbkar, who will be moderating and judging today's presentation. Dr. Nimbkar brings with him a wealth of clinical expertise and academic excellence, and we're grateful for his continued support and mentorship through the GynoScope series. Presenting case today are two incredibly promising undergraduate students, Parth Shah and Mangesh Shep from the esteemed Seth GS Medical College and K.E.M Hospital, Mumbai. We look forward to the clarity, clinical reasoning, and depth they bring to today's case. Do note that the presentation will be judged on the following parameters: history 10, examination 10, management and understanding of the topic 10, communication 10, higher order thinking 10. Thank you once again for being here, and we hope this session leaves you not only informed but also inspired. Let's begin.
Parth, you may read out the case just like our previous
Yes,
session.
sir.
You
Yeah,
read out
I
the
shall
entire
proceed.
case gradually and then I will start. Okay, all the best.
So, the patient, Mrs. ABC, 29-year-old male, residence, Kurla, Mumbai. She is housewife and married since last 5 years, and it was a non-consanguineous marriage. The obstetric score is G4, P0, L0, A3. The socio-economic strata is lower middle class as per BJ Prasad scale. Her last menstrual period was 11th December 24, and the expected date of delivery as per Neglis formula is 18th of September 2025, and her gestational age is 30 plus 1 weeks, calculated as per LMP. The chief complaints: the patient came for routine ANC visit and was referred from her primary healthcare center for safe confinement in view of bad obstetric history. The patient had no complaints as such and was referred for evaluation for having a bad obstetric history. First trimester, the history of current pregnancy. In first trimester, the pregnancy was a spontaneous conception diagnosed at 5 weeks from LNP and confirmed through a UPT test. And she was registered for ANC visits and started with folic acid supplements. A USG scan was done and indicated single gestation. There was no history of excessive vomiting, abdominal pain, per vaginal bleed, per vaginal leak, fever, skin rashes, swelling of feet. In second trimester, the patient was started with iron, folic acid, and calcium supplements. TD doses were given in second trimester, 4 weeks apart, and quickening was first seen in fifth month. The USG scan was done, and the patient was told that there was no abnormality detected. Patient was told that her cervical length is less than 2.5 centimeter, and hence procedure for cervical stitches were given. There is no history of excessive vomiting, abdominal pain, per vaginal bleed, per vaginal leak, fever, skin rashes, swelling of feet. In the third trimester, iron, folic acid, and calcium supplements are continued, and fetal movements are perceived. There is no history of abdominal pain, per vaginal bleed, or per vaginal leak. It's a negative history. There is no history of gestational diabetes mellitus or overt diabetes mellitus. There is no history of hypertension, thrombosis, thyroid disorders, teratogenic drug intake, radiation exposure, autoimmune diseases, RH incompatibility, PCOS, any past uterine procedure or MTB performed, no history of any infections in the pregnancy. Then past obstetric history, G1A1, it was conceived naturally in 2021 February. All ANC routine investigations were normal, and at 16 weeks of gestation, she noticed a painless expulsion of fetus, which led to spontaneous abortion. Then her second pregnancy, which was conceived in July 2022, again the routine investigations were normal, and at 14 weeks of gestation, she had a similar episode of painless expulsion of fetus leading to spontaneous abortion. The third pregnancy was conceived in 2023 March. and the routine investigations were normal. And at 18 weeks of gestation, she noticed painless expulsion of fetus, leading to spontaneous abortion. Then menstrual history, her menarche was at 13 years. Her LMP is 11th of December 2024, and expected date of delivery is 18th Sep- September 2025. Cycles were regular 28-day cycles. The bleeding was there for 3 to 4 days, and she used 2 pads per day. There was no clots or excessive abdominal pain or dysmenorrhea. Then past history, she has a history of cervical surplush done at 14 weeks in their current pregnancy. There is no history of diabetes mellitus, no history of hypertension, no history of endocrinopathies, no history of epilepsy or epileptic disorders, no history of TB or TB contact, no history of any medical illness. Then her dietary history. um, She consumes mixed diet. Breakfast is around 300 kilocal, 12 gram protein. Lunch is 900 kilocal, 18 gram protein. Snacks 300 kilocal, 10 gram protein. Dinner around 1000 kilocal with 20 gram protein. Final is around 2500 kilocal in the normal range. And protein is she is having a 5 gram of protein deficit. Then family history, there is no family history of recurrent abortions in her mother, her sister, or her aunts. No history of congenital anomalies or connective disorders in the family. Then the patient had gained a weight of 8 kg from 50 kg to 58 kg. Her height was around 155 is around 155 centimeter. She denies any history of addictions. Bladder bowel function was normal and sleep was adequate. Then Mangesh shall proceed with exam.
Am I audible?
Yes, Mangesh, you are audible. You can continue.
The patient is examined with due consent in presence of female attendant in well-lighted area. The patient is conscious, alert, and oriented to time, place, and person. The patient is average built and adequately nourished. Weight gain is 8 kg from 50 kg to 58 kg and height is 155 centimeter with preconception BMI being 20.8. Pulse 90, respiratory rate 16 breaths per minute. BP 116 by 74 millimeters of mercury measured in right upper arm in sitting position. Pickle is absent. Breast normal and pregnancy related changes were present. Thyroid non palpable. Systemic examination. Abdomen shape is symmetric. Generalized abdominal distension. Stria gravidarum present. Linea nigra present. Umbilicus central and everted. No dilated veins, scars and sinuses. Palpation. Symphysiofundal height 30 cm correlates with 30 week of gestation. Abdominal circumference 85 cm. Leopold's manual. First grip. Soft, broad, irregular, non-ballotable mass felt suggestive of fetal buttocks. Second grip. Right. Small, knob-like structures felt suggestive of fetal limbs. Left side. Smooth, curved structure felt suggestive of fetal back. Third grip. Hard, round, ballotable mass felt suggestive of fetal head. Fourth grip. The hands are converging and the presenting part that is head is not engaged. Other systemic Other systemic examination. CVS. S1 S2 is normal. CNS no focal neurological deficit. Respiratory system. Bilateral air equal entry. Fetal heart rate is 120 beats per minute. Provisional diagnosis. 29-year-old G4L0P0A3 with history of recurrent second trimester losses with no known risk factors present in is a case of recurrent pregnancy loss with etiology being cervical incompetence, uterine abnormalities, Aplas syndrome, hypothyroidism, and fibroids. Investigation: CBC, LFT, thyroid function test, USG. Diagnosis: a G4P0L0A3 with recurrent painless second trimester pregnancy losses 16, 14, and 18 weeks, now at 30 plus 30 weeks and 1 day gestation with elective cyclage done at 14 weeks, likely etiology of cervical incompetence.
Okay, Mangesh, that's a decent presentation. Uh, Same path. Mangesh, just a couple of things. Please note that don't use the acronyms like pickle or G2P1L1. You have to be using the entire full form of it in every single exam. No examiner is going to like being told those acronyms. So never say pickle, say it in entirety, palarectris, cyanosis, clubbing, lymphadenopathy, and edema. Also, the same thing goes with your parity score. Mention it in
Okay, sir.
entirety. Gravida 4, abortion 3. If you don't mention para 0, living 0, that is okay. You can just mention gravida 4, abortion 3. But anyway, that's a good presentation. And that's a very, very good case. That's an excellent case. Could you go on to your next slide, please? Okay. So now, before we begin, now it is very obvious that yours is a case of recurrent pregnancy loss. The first and the most important question: how do you define recurrent pregnancy loss?
Uh, So we defined it recurrent pregnancy loss as having three or more pregnancy losses before 20 weeks of gestation. And as per latest RCOG guidelines, we can consider abortions before 24 weeks as well as in the recurrent pregnancy loss.
Okay. Uh, do you think that all the guidelines consider the ASRM classification, all the classifications that we have, consider it as three or more, or is there um, some discrepancy in that? Is there anything different?
Some classification and systems also mention that if the clinician suspects, then he can consider RPL even if there are two or more cases of abortion.
Yeah, very good. Pretty good. So the thing is, there are various organizations. You at this point do not need to know those organizations. Now, if I'm going to be reading out, I'm actually quoting the RCOG guideline over here. So in RCOG, they have mentioned that there are multiple guidelines that have various definitions. So the American guidelines, the American Society for Reproductive Medicine, that is ASRM, they say that you can begin the evaluation even if you have two pregnancy losses, whereas ESHRE, that is a European guideline, even they recommend that you can start doing your investigations or evaluation after two pregnancy losses. Though the RCOG latest guideline says that you can do at three. Now it's a question of what do you want. Now, if you have a patient in today's world who has come to you and has told you that she has already had a second pregnancy loss, or maybe she is coming to you with an ultrasound that shows that she is having a missed abortion again. This is the second time that this has happened. You wouldn't tell her that you merit an investigation or an examination after you have yet another pregnancy loss. Every single pregnancy loss is a big psychological event for that couple and more so for that female. Although for us as clinicians, it is probably not that big a thing, but for them, it's a big thing. So, on a practical note as well, in your practice, you probably can consider just starting the evaluation after there have been two losses. So yes, you are completely correct when you just quoted the RCOG guideline, which says three and more than three. But even at your second pregnancy loss, you can start doing the evaluation. But yeah, you are correct. You can mention this in your exams as well that there are various guidelines, and all those various guidelines are two or three. But I would practically want to begin my evaluation after two, given that more and more so if the female is elderly, she has crossed 30, she doesn't have too much of time with her ovarian reserve, then all the more reason for me to begin it early. Fine. Now, in your demographic details, Parth and Mangesh, What are other significant aspects?
So one significant, not in this pregnant as a case, but some of this can be the age. The patient is currently 29 years, but in advanced age, there is very high risk of abortions.
Very good. Why? Could you tell me just why?
Just because as the maternal age progresses, the quality and the there is increased risk of meiotic defects in the ovum, and also there are poor quality ovum produced. So there can be
Very good.
increased risk
Very
of
good.
chromosomal abnormalities.
So disjunction events, disjunction problems will start arising, meiotic events. Correct. Very good. And what about teenage pregnancy? Is this more seen in teenage pregnancy as well, or no, young age is not a risk factor?
Um, yeah, sir. The other extreme of age can have increased risk of abortions because the reproductive tract is not well developed.
Okay, that is one way to put it. That is okay, fine. I'll give that to you. Good. So it is more so extremes of ages again. Okay. Residence, does it have anything to do with that? Does it have any correlation?
So in some places where there is sickle cell predominance, there can be abortions because of sickle cell anemia if the fetus is having sickle cell disease in both. So, like there can be a risk of abortions, recurrent abortions if both the parents are carriers.
Okay. Co-
And plus, sir, in the thyroid means hypothyroidism in the places where the iodine deficiency is there. But now the before this will happen, hypothyroidism and that causes
yes,
also
correct.
recurrent pregnancy loss.
So most of the country right now receives iodized salt, but in areas, if there are any which are still using non-iodized salt, those areas might be susceptible to thyroid disorders. Correct. Coming back to your point, Parth, you just mentioned regarding a sickle cell. That's a good point, but your explanation is slightly off. Remember that sickle cell disease is never going to manifest in utero and is never going to lead to fetal demise. It may happen in alpha thalassemia major, lesser chances of it happening with beta thalassemia major in the fetus, very less chance of it happening because of sickle cell disease in the fetus. Instead, the reason that these women have multiple abortions is that because of the sickling crisis, your spiral arterioles may get blocked. And that is why you may have poor placentation or you may just have poor blood supply to the endometrium. That may lead to your recurrent abortion. A far-fetched one, but that's a good thing that you stated. We have many regions that are endemic to sickle cell traits, sickle cell carriers. So yes, this is the reason in them. But yeah, you were close. So that's a good point. Residence, great. One thing about residence, if there are people now, you have mentioned Kurla. For all the people who are not from Mumbai, Kurla is an area where the density of population per house is quite high in the higher side. So a lot of low socioeconomic strata people stay over there. So if you're going to be talking about this, in other histories like medicine and surgery, we often talk about something called as infections, more so tuberculosis. Would you attribute recurrent pregnancy loss to infection?
No, sir. Commonly, due to infections, recurrent pregnancy loss does not occur
Very
because
good. Excellent. Yes. Why? Continue.
sir, because if the infection occur at the first time of the pregnancy, then we will detect and treat them, and antibodies form against that organism. So most commonly at the second time, we cannot occur that due to same condition,
That's a
same
wonderful answer,
infection.
Mangesh. Could you just tell me one such example of an infection? Because tuberculosis will not have immunity. So, any other infection in which the thing that you spoke of will happen?
Sir, like in syphilis, we have occur recurrent pregnancy losses, but the time of period of gestation increases, like
Very good. What is
Kassovitz
that
law.
law? Cassava. Okay,
Kassovitz
excellent answer. I love that answer. Very good answer. Any other very common intrauterine infection or a set of infections?
torch infections.
Torch infection. Excellent. A point to be noted over here for all the undergraduates and even postgraduates. A lot of people do testing for torch in recurrent pregnancy loss. Remember, it is pointless. It is pointless because you will already be immune and it might lead to one pregnancy loss, but not multiple or recurrent pregnancy losses. Plus, once you have gotten the infection, as Mangesh mentioned, you become immune to it. You develop antibodies, and those IgG antibodies are going to be made, which are going to make you safe against the same infection in the next pregnancy. So it is pointless, absolutely pointless to test for TORCH. It's an expensive investigation. It has absolutely no value. So, in any case with spontaneous abortion, avoid doing that expensive test because it is not giving you anything. Don't do it. Good answer, Mangesh. I like that. Syphilis, very good. And could you just mention the law again?
Kassovitz law.
Kassovitz law.
In
Correct. Very good. In which the gestation increases, keeps on increasing with each subsequent pregnancy. Good. Next, I come to marriage, non-consanguineous. No, 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 just seems like. Consanguinity. What's your view on consanguinity?
So if the person is having consanguineous marriage or between the siblings or between the first degree cousins, there are high risk of chromosomal abnormalities or genetic defects, congenital anomalies.
Very good. Now, the RCOG guideline that you quoted earlier, it explicitly says that consanguinity is no longer a risk factor for recurrent pregnancy loss, but I do not agree with that. And you are correct that consanguinity will lead to all these disjunction problems, genetic problems, and that is going to lead to spontaneous abortions and recurrent pregnancy loss. So, yes. The reason, though, there has to be some reason why a body has said that consanguinity will not make a difference. Would you want to attempt reasoning that part? Why must they have said that? Am I audible?
Yes,
yes, sir.
Okay, would you want to attempt that? Just try attempting. Why will it not lead to recurrent pregnancy loss, consanguinity? Why they must they have said like that? Okay, so
Sir,
I'll tell.
can I
Yeah,
say?
you want to attempt, Mangesh? Yes.
Yes, sir. Sir, because if there is a consensuous marriage and one pregnancy loss has happened, then we will do karyotype and find the chromosomal abnormality is there present. If we done that, then next time it will not occur, or other we can take
That's a
other
good
techniques.
reasoning. That's a good reasoning, but I can give you a little more scientific reasoning. You were mentioning that consanguinity increases the risk of autosomal recessive disorders, correct?
Yes,
Now, the commonest autosomal recessive disorders, could you quote a few of them?
sickle cell anemia.
Sickle cell anemia, more, a few more. Beta thalassemia, a few more. There are so many of them. There are so many. There's an entire list of autosomal recessive disorders. Parth, do you want to
hemophilia,
attempt this?
hemophilia,
Hemophilia, very good. What else?
then in inborn errors of metabolism like glycogen storage diseases,
Good. Yes.
G6PD,
G6PD. Okay, great. A few more like alkaptonuria. You have even congenital adrenal hyperplasia. We spoke about it in the last session. You have homocystinemia, again, something that we had spoken in the last session, hemochromatosis, Wilson's disease, a very significant one. The thing here is, all these disorders in the fetus, autosomal recessive disorders in the fetus, are not going to lead to pregnancy loss. Those pregnancies will mostly continue. They might have an intrauterine fetal demise, or they will be born and they will have a poor quality of life. A few may even succumb in the first few days of birth. So it might become a case of bad obstetric history, but not recurrent pregnancy loss. Samjhe, autosomal recessive is
yes,
not lethal. Genetic disorders might be lethal, but consanguinity is leading to more so autosomal recessive disorders, and that is why they have said that consanguinity is not that big a risk factor. Got it?
yes, sir.
Okay. So basically, autosomal recessive disorders are not lethal enough for them to cause recurrent pregnancy loss. They will eventually die at some point, or they will have a poor quality of life. it will be called as a bad obstetric history, but not as recurrent pregnancy loss. Anyway, your obstetric score is abortion 3, and all of them are second trimester abortions, right?
Yeah, sir.
Okay, come to that later. Your LMP, and she's at 30 weeks of gestation, so she has successfully bypassed that danger red zone that she had in her previous pregnancies, thanks to the circlage. Okay, next slide. Chief
Patient
complaints.
had,
Okay, okay. So basically, she's an OPD patient, right?
yeah, sir.
Good. Okay, continue. Next slide.
So this is the history of current pregnancy.
Current
Uh,
pregnancy. So the pregnancy was a spontaneous conception at 5 weeks of gestation. No history of excessive vomiting, poor vaginal bleeding. The patient was started on IFA and calcium supplements. Doses were given. Okay. Um, ठीक Now, is there one such drug that a lot of clinicians start in the first trimester, and they started in patients with recurrent pregnancy loss? And although they may not have a report to justify that, that drug actually works. So, which is that drug? Please listen to me carefully. I have said they started from first trimester. Ecosprin, there's a wrong practice. A lot of people are commenting Ecosprin. There's a very, very wrong practice of starting it in the first trimester because there are theoretical risks of teratogenicity. It has to be started from 12 weeks. Few people are mentioning folic acid. No, folic acid is not the answer because folic acid is not started in the first trimester. It is started 3 months before conception to prevent neural tube defects. So, which is that one drug that people start? Don't look at the comments. They are grossly wrong. What's your answer, Parth?
I can't think of any such drugs.
Okay, Mangesh, do you know of any such drug that a lot of obstetricians start in the first trimester in patients with recurrent pregnancy loss?
Sir, no, sir. We start progesterone, but after we diagnosing progesterone and aspirin, we start after diagnosis of cervical circlet.
Okay, so the answer here is LMWH, enoxaparin, which is the brand name of it. LMWH is started. Parth, Parth or Mangesh, do you want to attempt why do they start this? What is the reasoning behind this?
So, like some of the clinicians might suspect that the previous abortions were due to APLA syndrome. So, as a precaution,
But then they can
prevention,
just
they might be
do an
giving.
APLA profile, which is going to cost what, some 1,500, 2,000 rupees, and they can confirm है या नहीं. और अगर नहीं है, तो just not start it. तो भी क्यों?
Sir, because there is a history of abortion and there is a history of thrombosis or any.
But there is no history. That is exactly my point. There is
So,
absolutely no history of.
if there are any inherited thrombophilias which not have been diagnosed, like protein C of antithrombin deficiency.
Again, you can just do those tests, and in pregnancy, by the way, you can test thrombophilias. I'll come to thrombophilias. But then, as I'm telling you, there is absolutely no report that the doctor has done, and they have just started it. I'll come to this point again. Everyone, just keep in mind my question right now. I'm putting it as a pending question. Why are people starting LMWH in first trimester? Before that, Parth, I would want you to answer. Since you mentioned thrombophilias, what are the types of thrombophilias that you know of that are significant to pregnancy?
So, there can be first can be congenital ones, inherited thrombophilias, like
Okay,
protein C deficiency, factor V Leiden mutation, antithrombin deficiency.
very good. That is good. That is good. And Mangesh, what are acquired thrombophilias?
Acquired thumb.
Parth, do you want to answer?
Uh, One can be APLA syndrome.
Very good. APLA syndrome, great. Your pregnancy itself is a hypercoagulable state. So
Yes.
even it technically forms a type of thrombophilia, although it is not thrombophilia, but it is a hypercoagulable state. But APLA syndrome, good. Could you tell me in your acquired, when you're talking about APLA syndrome, how do you diagnose APLA?
So we have clinical criteria and biochemical criteria. In
Okay,
clinical
what is the name of this
criteria,
classification?
um,
Sapero
Oh,
criteria
yes,
name is
Sapero. Yes,
Sapero,
correct. Sapero criteria. Next.
and I think उसका दूसरा नाम सिडनी क्राइटेरिया भी है.
Sydney criteria भी एक बराबर एकदम बोला मंगेश कड़ा. So yes, tell me, any one of you, the criteria. Quickly tell me. Brief
so
me out.
clinical criteria is that more than three consecutive pregnancy loss at less than 10 weeks, or more than one spontaneous
Mm,
pregnancy
mm, mm,
loss
mm. Do you
about
think
10
you
weeks of
can? No,
gestation.
no, no. Do you think you can just frame it a little better? You're talking
The
about one sub
patient
point.
patient should have history of any thrombotic event.
This is
Uh,
again a sub point. Just go slightly above. One clinical criteria plus one laboratory
one
criteria.
lab biochemical criteria.
Yeah, one laboratory, biochemical criteria. Now, what you are talking about is clinical criteria.
Clinical
Under
criteria.
clinical, you have pregnancy criteria and non-pregnancy criteria. Now,
Yes,
tell
sir.
me,
The non-pregnancy criteria can be there has to be one or more than one episodes of arterial or venous thrombotic events.
like,
Like there can be DVT,
hmm,
then
yes,
there can be angina, uh,
okay, very
MI,
good. Ischemic heart disease, yes.
ischemic heart disease, then
Ischem
pulmonary thromboembolism,
okay, pulmonary thromboembolism, ischemic stroke, any event.
ischemic stroke.
Yeah, cerebral venous sinus thrombosis, any event anywhere in the body that was attributed to a thrombus inside it makes a patient fulfill the clinical criteria, the non-pregnancy clinical criteria. What is the pregnancy criteria?
The pregnancy, there are three criteria in the pregnancy criteria. Uh, first one is that there should be more than three consecutive pregnancy losses at less than 10 weeks, or
Okay,
more than one, yes, sir,
correct, correct, correct.
more than one spontaneous pregnancy loss at more than 10 weeks, or a case of preterm birth of a morphologically normal fetus, which is less than 34 weeks, a preterm birth, because of severe preeclampsia or placental insufficiency.
Basically, because of some placental disease. Placental disease can be abruptio, eclampsia, severe preeclampsia, or FGR, fetal growth restriction. Okay,
Yes.
yeah. What is your laboratory criteria?
So lab criteria, we have analysis of three antibodies. First one is lupus anticoagulant.
Okay,
Uh, then we have anticardiolipin antibody IgM IgG,
okay. What
and the
else?
third one is anti beta microprotein 1.
Could you just tell me the antibody again? The last
Uh,
one?
Anti
Yes,
anti beta
Mangesh?
2 glycoprotein 1.
Very good. Anti-beta 2 glycoprotein 1. Fine. So what are these antibodies? They are all anti-phospholipid antibodies. Okay. So
yeah,
anywhere in your body where you have phospholipid, they will go and attack it. They will go and destroy it. It can be your renal artery. It can be your coronary circulation. It can be your deep vein thrombosis wale apne deep veins of the lower limbs. It can be anything in your body. It can just go and it can destroy it. What concerns me during pregnancy is its ability to go and act on the endothelium. That is my endothelium ka jo phospholipids hai of my spiral arterioles, which will block the spiral arterioles. Because whenever there is endothelial damage, there is going to be platelet plug formation and coagulation factors will accumulate and form coagulate karenge wahan pe, and that will lead to blockage of blood supply to the placenta. So the spiral arterioles are going to get blocked. Now, these are only three of the several hundred antibodies that we have seen for anti-phospholipid syndrome. ये तीन सबसे कॉमन है एंड ये तीन सबसे कॉमन है प्रेगनेंसी में खराब आउटकम्स लाने के लिए. टू हैव बैड आउटकम्स इन प्रेगनेंसी, these three are the commonest ones. But whenever you are doing an APLA profile for a patient, and there has been like you have a suspicion that in her previous pregnancy she had preeclampsia, severe preeclampsia, she had abruptio placentae, she had eclampsia, and there was a fetal loss. You have tested the APLA profile किया है, ये तीनों antibodies check किया है, but ये तीनों negative आ गए, and you still have a doubt. In that scenario, we go ahead and we do an extended APLA profile. एक्सटेंडेड एप्ला प्रोफाइल जो होता है उसके अंदर बहुत सारे हम फॉस्फोलिपिड के टारगेट्स ढूंढते हैं बॉडी में और उसके अगेंस्ट एंटीबॉडीज कौन से पॉजिटिव है हम देखते हैं. सो फर्स्ट थिंग इज whenever we are checking for APLA profile, if it is negative, it does not directly imply that a patient is completely APLA negative. You do not rule it out. You preferably do extended APLA profile if there is a history that is suggestive of one of these clinical criteria. But the problem is that this is an expensive test, and hence the clinicians say that we might just start this female on LMWH because it may act against any one of these antibodies and it will prevent the coagulation formation. That is the first reason why they started empirically. The second reason why they started empirically is of the three, the most dangerous antibody is your beta 2 glycoprotein antibody. The worst prognosis in pregnancy is because of beta 2 glycoprotein. LMWH is known, or any heparin, LMWH or unfractionated, it is known to go and bind to these antibodies and destroy them. Basically, it protects your beta 2 glycoprotein in the body. In your body, beta 2 glycoprotein is normally present. Anti beta 2 glycoprotein is the problem. The antibody against beta 2 glycoprotein is the problem. So, the work of LMWH is to destroy that antibody and to keep that beta 2 glycoprotein safe. Now, this beta 2 glycoprotein is a very important molecule in the placenta because it provides nutrition to your syncytial trophoblast. It also increases the blood supply to these placental syncytial trophoblasts, and hence giving LMWH is going to help these beta 2 glycoprotein molecules survive and not get destroyed by the antibodies against it. And hence, even though in the market you have a cheaper alternative in warfarin, which is almost 1 rupees per tablet, 1 or 2 rupees per tablet, and something warfarin is a better anticoagulant, so it is going to give a better anticoagulating action. Yet the drug of choice for APLA syndrome prophylaxis in pregnancy happens to be LMWH or unfractionated heparin. The reason is this. LMWH will go and bind to these antibodies and will destroy them, whereas warfarin is not going to do that. So it is acting at the root problem. It is not waiting for the coagulation to happen and then to stop it like warfarin. It is actually inhibiting these antibodies, and hence LMWH is often started by a lot of people in the first trimester empirically. One more thing. These are all antibodies, and to suppress antibodies, there is another drug that I have in my bank, and that is a corticosteroid. Hence, a lot of clinicians also start prednisolone. Visolone नाम का उसका ब्रांड नेम है. काफी लोगों के प्रेस्क्रिप्शन में तुम देखोगे वाइसोलोन स्टार्ट किया है, प्रेडनिसोलोन स्टार्ट किया है, एंड यू हैव नो आइडिया क्यों स्टार्ट किया है. तुम लोग जाके देखते हो उसको ऐसे लिए कुछ था क्या? कुछ नहीं था. क्यों स्टार्ट किया? बिकॉज this corticosteroid in its lowest possible dose is going and inhibiting all these antibodies in the body that are destroying various targets in my placenta. Not just this beta 2 glycoprotein, but various targets. ऐसे बहुत सारे targets है उसको वो destroy कर रहा है. ये prednisolone रोक देता है because of its immunosuppressant action. And hence, the two drugs that are often empirically started are LMWH and prednisolone. And though the literature is dicey on it, the outcomes have been good enough. It has shown that babies have had higher birth weights. Fetal growth restriction nahi hua hai after you have started them empirically on LMWH. This is the reason. The circulation is maintained because of that LMWH. Did you understand this point?
Yeah, sir.
Okay. Kshitij has asked, what do I follow? Kshitij, currently I work in K.E.M hospital, which is a government setup. In a government setup, for me to give heparin, the patient has to be able to afford it. It is literally 200, 250 rupees per day minimum. Generic वाला. अच्छे quality का heparin तो और भी महंगा है. So take it across the pregnancy, it is going to cost somewhere between 40, 50,000 कम से कम. I cannot afford that. Patient cannot afford that. And hence, I prefer to not start them empirically. Okay. There was one thing that you missed in your Sapporo criteria, in your laboratory criteria. What was it?
So that their antibodies should be detected at two occasions and they should be 12 weeks apart.
12 weeks apart. Excellent. But 12 weeks is equivalent to 3 months. 3 months में तो ये pregnancy abort हो जाएगा. So would you want to wait upon for 12 more weeks to start the patient on LMWH? तेरा एक
So,
positive आ गया है report.
so if the first report is positive, then we can do the second one within 6 weeks apart.
But 6 weeks is again 1.5 months. What if the female aborts? तेरा एक criteria तो 10 weeks के नीचे abort करने वाला है ना? Recurrent pregnancy loss because of APLA के वजह से. तो 6 weeks में तो 10 weeks चले जाएंगे and she might again abort. Do we have a provision for this? That is my question. Have we made something so that we can bypass this rule?
सर मिनिमम टाइटर जो टाइटर है उसके अगर अबव होंगे तो हम स्टार्ट कर सकते हैं टाइटर। अभी उसका एग्जैक्ट वैल्यू मुझे
Good.
नहीं याद
Yes,
है।
yes, we can start it if the titers are more, or even if they are just positive, we give the benefit of doubt to the female. And this exactly, एक बार positive आना, if your APLA profile में से कोई भी antibody, even if it is positive once, and there is a history of previous pregnancy loss, you call this OAPS, obstetric antiphospholipid syndrome, or obstetric APLA syndrome. That is basically, even if one report comes out to be positive, she meets the criteria for OAPS and you start her on LMWH. You do not wait for 12 more weeks for confirmation, not even 6 weeks. This is one of the newest terminologies, OAPS. It comes alongside another terminology that you should know, and that is catastrophic APLA syndrome. Parth, Mangesh, do you know what is catastrophic APLA syndrome?
नो सर।
Catastrophic Aplar syndrome, CAPS, is basically when there is complete end organ damage because of some obliteration. So, multisystemic or basically target organ damage because of clotting or blockage is called as catastrophic Aplar syndrome. Usme patient is almost as good as gone. The patient will have very high mortality rate. Okay? So these are few important terminologies that I would love you all to know and remember and be able to practice in the exam. Before we proceed, has everyone understood this nice little concept of LMW? Just let me know in the chat. Until then, I'll proceed with the conversation. Just let me know in the chat if everyone has understood this LMWH वाला rare concept. This is very कम जगहों पे बहुत दिया गया है. एक पैराग्राफ है सिर्फ एक बुक में जो मैंने पढ़ा था, इसलिए ये मुझे याद था. Okay. So now in your pregnancy, the patient in second trimester, you have mentioned that her cervical length was less than 2.5 centimeter and hence cervical stitches were taken. So what is the cervical stitch called as?
This is called cervical circlage.
Okay, cervical circlage. So what are the indications for cervical circlage?
So indications can be on USG if the cervical length
Can
is
I interrupt you
less than
once?
2. Yes, sir.
Can I interrupt you once? There is a question
Yeah,
that
yes.
someone in the audience has asked, which says, why is it necessary otherwise to diagnose them 12 weeks apart? Antiphospholipid antibodies जो है.
Yes, sir. Can you repeat the question?
There is one question that has been asked in the audience. Why is it necessary that the antibodies have to be checked twice, 12 weeks apart?
Yes, sir.
The reason is that अपने body में काफी सारे ऐसी जगह है जहां पे there is going to be a false positive antibody का titer that is going to be seen, and hence I do not want to rely on just one report. These antibodies could have bound to some other target and उसके वजह से वो positive आया रहेगा. I do not want that to happen and hence I would want to confirm that it was not an amnestic response and hence I would be testing it twice. Anyway, so continue. Yeah. So what are the indications for circlage that you were saying?
So firstly, the woman should have history of more than three second trimester pregnancy losses or preterm deliveries.
Okay.
Then on USG, the cervical length should be less than 2.5 centimeter.
Okay. Which is this criteria that you're speaking of?
This is the USG criteria.
Okay. And
Then
And
yes, continue.
internal os diameter is more than 2 centimeter on
Okay.
USG.
then a
So do you
bulging
have
of
any guideline
membranes.
that you can quote? Any guideline that you can quote for cervical circlage wala koi better thing, something better? Because what answer that you have given is still not convincing me enough. So there are three types of circlages that are present. Three indications. One is history indicated, wherein you have proper history of two or three, whatever you are considering significant, two or three second trimester losses, and you know as a fact कि ये हुआ है because of that cervical incompetence. And now in this current pregnancy, you do an ultrasound और उसपे USG से length छोटा आ जाता है. That is your history indicated. The second is ultrasound indicated, wherein you have history of only one second trimester loss, but in current pregnancy, you have a USG that is showing that your cervix is short. Whereas the third one is going to be your emergency circlage. Emergency circlage is done even if in the first pregnancy there is evident cervical dilatation, and then you do not wait for it to deliver preterm and for it to become a history indicated circlage. So you do a history indicated circlage between 11 to 14 weeks. You do a USG indicated circlage between 16 to 24 weeks, and between 24 to 28 weeks, you do an emergency circlage. You do not do any circlage beyond 28 weeks because the risk of cervical tears, chorioamnionitis, all these increase. And at 28 weeks, the baby is good enough to be survived in a good NICU setup. So even if the baby is to be delivered after 28 weeks, I can still have it in the NICU and it can recover. So after 28 weeks, you preferably will not do any circlage. Your maximum limit is going to be 28 weeks. The earliest limit is 11 weeks. Why?
So, because in some pregnancies, if you are not sure of cervical incompetence, and in some pregnancies, there can be pregnancy loss because of genetic anomalies, congenital disorders, but they mostly occur in the first trimester itself. So, we wait till the first trimester is over so that we can be sure that the cause is cervical incompetence.
Excellent. So basically, the better way of putting it is most of the spontaneous abortions because of chromosomal or genetic abnormalities happen till 10 weeks. You wait till 10 weeks so that if this current pregnancy has something that is abnormal, it will abort. And I will not conserve or I will not put a circlage on an abnormal fetus. That is it. Got it?
Yes.
Okay. So you attempted a history indicated circlage. What are the various ways of testing for cervical incompetence?
So we can be using Hagar's dilator,
Okay, what size?
8.
Yes, number eight. Yes.
Then we can use a 14 number Foley's catheter.
Okay.
Uh,
Just the
then
catheter, or do you want to inflate it?
we will wish to inflate it with saline and then pull it out with a traction force. If it gets pulled out with the traction force of less than 600 grams, then we can consider it as a it can be considered for diagnosis of cervical incompetence. Along with the Hagar's dilator can be passed with easy force, with little to no force.
Okay. Um, 600 gram. Can you ever calculate how much of force you're applying? Is it a practical thing to do?
Not really, sir.
Yeah, exactly. So what you will instead do is you will just try to pull it out and you would see if it is getting pulled out easily, you will not do anything. It is a direct indicator that your cervix is incompetent. Also, you didn't tell how much of normal saline will you fill in that balloon.
1 ml.
2 ml. 1 ml is a little too less, it is 2 ml. 2 ml in 14 French Follies to be inserted and then to be pulled out. If it is getting pulled out very easily, the cervix is incompetent. Apart from that, you mentioned about Hega's dilator. It is both ways. Ease of putting inside, whereas when you're pulling it out, the interos offers no resistance. So while putting it in as well and pulling it out as well, you can know whether the cervix is incompetent. Okay. Any other ways, any sophisticated ways that we don't really use, but any score वाला ways कोई है जिसमें हम score दे सकते हैं, scoring कर सकते हैं?
There is one cervical compliance index.
Very good. Cervical compliance index, which you don't need to know at your stage. It is an index जो हम लोग hysteroscopy पे determine करते हैं by calculating the canal is to cannula ratio. Canal is basically a cervical canal. Cannula is the hysteroscopic cannula that you insert. And the ease at which you are inserting the cannula, उससे एक ratio निकलता है. If the score is more than 2, then you say that the cervical compliance index is positive and the cervix is incompetent. Okay. So you have diagnosed a cervix to be incompetent in your at your 11 to 14 weeks scan pay. You want to put up a circlage. How do you proceed? What are the investigations that you would do? 13 weeks.
We can do a USG to confirm if it is not a molar pregnancy.
Okay. Okay, very good. So USG to determine whether the fetus is normal. At least like NT&V scan में कर सकता हूँ. Basic. Okay, what's next?
Then we have to check whether the membranes have not ruptured.
Okay, membranes have not ruptured at 14 weeks. Okay, what else? 13-14 weeks पे क्या membranes rupture? वो इमरजेंसी सर्कुलर
There's
का तू बात
likely
कर रहा है.
there should be no placenta previa or abruptio placenta.
ओके. अब्रप्शो.
And
अरे 13 वीक्स का मैं बात कर रहा है. 13 वीक्स पे क्या क्या करेगा तू? 13 वीक्स पे
Sir,
कौन सा तेरा प्लासेंटा प्रीविया और एब्रप्शो?
sir, we will look out for organ anomalies like spina bifida and encephaly.
Yes, very good. Gross abnormalities that can be detected at NT&B scan, you will look at them. Yes, what else?
Is the pregnancy is viable or not? Cardiac activity we can see on USG.
हाँ, वो तो हो गया, कंफर्म हो गया anomalies. What else? You will want to look if there is any local infection. You would want to rule out infection. Vaginal infection कुछ है क्या? Bacterial vaginosis कुछ है क्या? If you have any urinary tract infection that can be transmitted through your urethra into the cervix and cervical region and can cause infection and abortion. So you would want to look out for these local signs. 13 weeks pay. But the points that you are telling me are all for that ultrasound indicated circulage in the second trimester between 14 to 24 weeks. ये 16 to 24 weeks. तभी जाके तू ये सब देख पाएगा प्लासेंटा प्रीविया है क्या, anomalies है कि नहीं, abruptio हुआ है कि नहीं. All these things are going to be seen in the second trimester. So you will also do an anomaly scan to look whether there is any abnormality or not, and if not, then you will do it. So what are the types of circulages that you can do?
so there are two types. One is Shirodkar's circlage and another one is McDonald's circlage.
Okay, are you sure there are just two types?
And there is a worms procedure as well.
Okay, are you sure there are just three types?
I don't know.
Sir, there are old surgeries also, but they now we don't perform that lash and lash surgery.
अरे सबसे important तेरा एक और जो main बच रहा है, abdominal circulage.
Abdominal.
Yes.
Your main classification is abdominal and vaginal circlage. You do not assume that circlage is an exclusive vaginal procedure. Remember, the higher circlage you take, the better the outcomes. And hence your abdominal circlage has the best outcome. Your McDonald, which is the lowest at your external os, has the worst outcomes. And beach वाला outcome है शिरोडकर का. So your answer is going to be abdominal. वहां पे भी open करूंगा या laparoscopy करूंगा, and vaginal. So in vaginal, you have the ones that you mentioned, Shirodkar and McDonald. Which is better and why?
So modified Shirodkar's is comparatively better.
What is the modification?
The suture is placed at the level of internal os after dissection and retraction of bladder.
That is Shirodkar. What is modification of Shirodkar?
Um, the knot was placed ideally anteriorly, but in the modification, it is placed posteriorly.
Yes, very good. So basically, to avoid erosion into the bladder, you have decided to place the knot posteriorly. Very simple. That is the modification, a very important modification. And what is the material that you use?
Marcelin tape
Marcelin tape. Okay.
or
Shifty
Prolene
just asked a
sutures.
question, a very interesting question. Why not always do abdominal circlage if it has the best outcome? What is your answer for this?
So there are certain complications, like if there is abdominal surclass is done, then the patient should always go for LSCS.
Exactly. Very good. Only method that you will have is going to be an LSCS because you cannot remove it vaginally and you can only remove that circlage abdominally. That is the biggest reason. Nothing else. And every female should definitely get a vaginal trial of labor. And if she already has an incompetent cervix, she has a good chance that she is going to deliver vaginally. So why unnecessarily make a female undergo a cesarean section? So that is the reason. There are ways, by the way, to cut the circlage, the abdominal सर्कलाज जिसमें हम लोग posterior fornix में जाके posterior vagina खोल के करते हैं but those are very dangerous ways and you can injure everything. I would instead just go for a cesarean section and hence that is the biggest problem. Okay. So which is the material that you use?
Marcelin tape, Prolene.
Okay, Prolene, muslin tape, or even ethylone sutures. A lot of people use nylon sutures as well. Basically, any non-absorbable suture. Why not an absorbable suture? Vicryl जैसा?
Sir, they will get absorbed the suture and then cervical incompetence then occur.
अरे
If
नो,
we,
सबसे बड़ा प्रॉब्लम हो जाएगा, एब्जॉर्ब होगा और वो स्टेनोसिस हो जाएगा वहां पे. You will just end up permanently closing the vagina, the cervix. You do not want to permanently close the cervix, na. You want to remove it at some point. So that is the reason you do not prefer to use a absorbable suture. You use a non-absorbable suture. Okay. In modified in Shirodkar, what is that you do which makes it better than Shirodkar?
There is the knot is placed posteriorly
No,
in
no, no. In
modified
Shirodkar
Shirodkar.
versus McDonald, how is Shirodkar better than McDonald?
Sir, it is Shirodkar is placed at the anatomical level of internal os,
Very good.
so it is more situated at the proper level.
Very good. Very good. So you push the bladder upwards and hence you put it there. But because it requires surgical expertise to push the bladder, a lot of people don't do that, but it's a very good way and you should learn it. Anyway, proceeding next slide.
This is a negative history of various etiology of second
Okay.
trimester pregnancy
Just one
loss.
question. When do you remove the cerclage ideally?
It should be removed at 37 weeks and or at the onset of labor. Uh,
Okay. What if you don't remove it and what if the female comes too late? What are the complications?
so complications can there can be a rupture of the cervix.
Okay. Cervical tears, complete cervical tears and traumatic postpartum hemorrhage. That's it. Okay. So in your negative history, you have mentioned about GDM, hypertension, thrombosis, thyroid, teratogenic drugs, autoimmune diseases, RH incompatibility, PCOS, uterine procedure, MTP. Okay. GDM, क्यों होगा GDM से RPL, recurrent pregnancy
So
loss?
there can be multiple mechanisms. One of the mechanism is that the hyperglycemia itself is teratogenic to the fetus,
Okay, very
and
good.
they
So it
can
is
cause
embryotoxic. Very good.
uh, yes, and it can also cause vasculopathic damage to the placenta.
Very good. Excellent. So chronic hypertension, chronic diabetes mellitus or overt diabetes mellitus can lead to placental vasculopathy. Okay. Um, thrombosis, hypertension, that's discussed. Thyroid disorders. How do thyroid disorders make a difference?
So thyroid.
And what are the normal thyroid levels that you would want to have in a female? A very important topic that a lot of people struggle with. Obstetricians भी endocrinologist के पास भेज देते, which is not required. What is the
Uh,
normal level of thyroid in pregnancy?
the normal level should be less, TSH should be less than 5 micro international.
Less than 5. Okay. Mangesh, any other answers for this?
Sir, I don't know the exact value of that, but the SCG and alpha unit of TSCG is same. That can alter the
Very good.
values.
That's a good part of the answer. I like that answer that you gave. So, in your first trimester, the lower normal is 0.1, 0.1. In your second trimester, it is 0.2. In the third trimester, it is 0.3. For all three trimesters, these are the lower levels. In the first trimester, the level is much lower क्योंकि body में कम TSH लगता है because your beta HCG is doing the work of TSH by binding to the thyroid gland and increasing the thyroxine production. But after 16 weeks in my body, the exponential increase in beta HCG plateaus out. It becomes constant. Apna body is much more sensitive to an exponential increase in concentration of anything. And once it plateaus out, all the receptors are desensitized. And hence, the body again starts needing TSH after 16 to 20 weeks because beta HCG has plateaued out completely. It is at a plateau. It flattens out. The curve flattens out. Hence, the need for TSH increases, and hence the lower normal limit increases across all three trimesters. In the first trimester, it is 0.1. In the second, it is 0.2. In the third, it is zero point 0.3. Now, the upper normal limit, there is a catch to it. For all women, anything more than 4, not 5, anything more than 4 is abnormal. You treat them. Definitely in pregnancy, you treat them. Between 2.5 and 4, you only treat those women who have three prerequisites. Either they have history of recurrent pregnancy loss, or they have history of infertility, or they have anti-TPO antibodies that are present, which is indicative of either Hashimoto's disease or autoimmune thyroiditis. So, if any one of these three conditions are fulfilled, then even if the levels are more than 2.5, you treat these women with levothyroxine. For all other patients, you can treat if the levels are more than 4. How do you treat it? The dose is going to be 1 microgram per kg. So if your female is having a weight of around, let's say, 50 kgs, she is going to receive a dose of 50 microgram. 60 kgs की है तो उससे थोड़ा सा कम डोज है 50 वो चल जाएगा. अगर 65 है तो 62.5 का डोज मिलता है मार्केट में वो दोगे तुम. ज्यादा नहीं देना, थोड़ा कम देना. If your female has a history of thyroidectomy, then the dose is going to be 1.6 microgram per kg and not 1 microgram. So it is going to be 1.5 times of normal. Now, if your patient is already a known case of hypothyroidism prior to pregnancy, in that scenario, what you will do is, Parth, Mangesh, do you want to answer?
Sir, as per the RCMG guidelines, if the patient is clinically euthyroid and but clinically euthyroid, then thyroxine supplementation is not recommended.
Okay.
But
दूसरे से
it may
बता
be
रहा
considered uh, if there is TPO is positive or the levels are more than 3 or TSH levels are more than 3 despite being subclinical.
हूँ. No. See, the question is simple. If you have a female who is already a known case of hypothyroidism before pregnancy, and now she has become pregnant, and if she is maintaining euthyroidism, by maintaining euthyroidism is if her level is less than 4 or 2.5, depending on those three factors जो मैंने अभी just बताया, in that scenario, all you will do is increase her dose by 25. That's it. Or the other way around, you can double the dose on Saturday and Sunday on weekends. Why? Because levothyroxine has a half-life of around 6 to 7 days, which is why even if you increase the dose of one day of the week, it will act throughout the week. So instead of one, we are increasing the dose for 2 days, that is Saturday and Sunday, because it is easy for the female to remember. So you have either of the two things that you can do: increase every day's dose by 25, or just make the weekend dose to be double. So if you was taking 50, so weekend पे उसको 100 देना है. That is all that you will do for patients who are known cases of hypothyroidism. That's it. So that is it about thyroid disorders. Also, anti-TPO antibodies, anti-thyroid peroxidase antibodies is one of those tests that a lot of people don't do. If your female is having a normal TSH but she has anti-TPO antibodies, then she is at a risk of having autoimmune thyroiditis at some point in the future. She's at a risk. And these patients might require to be started on levothyroxine. So उस केस में subclinical hypothyroidism is an important common concept. Subclinical hypothyroidism मतलब your patient has, would you want to answer what is subclinical hypothyroidism?
So the TSH levels are raised, but clinically there are no features of hypothyroidism.
Basically, your T3, T4 are normal, but TSH is raised. Your hormones, your
Yes.
active hormones, T3, T4 are normal, but your TSH is high. High मतलब between 4 to 10 के बीच में है तो ये केस में प्रेगनेंसी में तो स्टार्ट करना ही है. नॉन प्रेग्नेंट फीमेल्स में इफ एंटी टीपो एंटीबॉडीज आर प्रेजेंट then you start them because at some point they will eventually develop hypothyroidism. So that is the importance of anti-TPO antibodies in patients with recurrent pregnancy loss. A very important test that a lot of people fail to do. Okay. Teratogenic drug intake. Okay. Teratogenic drug will not lead to recurrent pregnancy loss. एक pregnancy loss हो जाएगा. ठीक है. Radiation exposure. Autoimmune diseases. Okay. Which autoimmune disease would you commonly associate with recurrent pregnancy loss and why?
One is APLA, other can be SLE.
SLE. So SLE में secondary APLA हो सकता है. Secondary APLA के वजह से there
Yes.
can be pregnancy loss. Okay. History of RH incompatibility. Will RH incompatibility lead to recurrent pregnancy loss?
So it can cause secondary recurrent pregnancy loss. If the first pregnancy had exposure to the maternal blood got
Correct.
exposure to the fetal blood.
करेक्ट. सो इट कैन लीड टू, और वो थोड़ा एडवांस जेस्टेशन में करेगा. बेबी जैसा थोड़ा बड़ा होगा तब जाके वो करेगा. ओके. एनी हिस्ट्री ऑफ एनी यूट्राइन प्रोसीजर और एमटीपी. नाउ व्हाट यूट्राइन प्रोसीजर?
Uterine procedure, if there is any DNC is performed,
What will that lead to?
so like it can cause adhesions in the uterus,
Okay. Called as
Asherman syndrome.
Asherman syndrome. So now that we have spoken about uterus anyway, could you tell me how is uterus responsible for recurrent pregnancy loss?
So uterus can be affected because there can be adhesions as mentioned in Asherman syndrome. There can be abnormalities like septate uterus and bicornuate uterus.
Okay.
Then it can be because of fibroids, submucosal fibroids.
Will bicornuate uterus lead to recurrent pregnancy loss?
Um, no, it should be
Only septate uterus is going to lead to recurrent pregnancy loss. Any other form में there is going to be an increased risk of malpresentations. Preterm labor होगा शायद क्योंकि uterine size is small, but the risk of recurrent pregnancy loss or infertility is only with septate uterus. ठीक है. बायकॉर्नुएट सब में बेबीज रहते हैं, मैल प्रेजेंटेशन में रहते हैं, ब्रीच में काफी बार रहते हैं, and they go into labor at 34-35 weeks of gestation itself. So do not mention bicornuate or unicornuate uterus in your exam. Definitely do not mention this. Only septate uterus is very important in the congenital वाले जो भी है वो. One more, any other Mullerian abnormality जो recurrent pregnancy loss या infertility cause करेगा? Infertility ज्यादा तो. Any सबसे बड़ा, सबसे dangerous.
uterine agenesis or
Agenesis. MKH, Mayer Kosser
Mayer
Rokitansky.
Koster Rokitansky's syndrome.
MR बीच का तूने R
MRKH.
मिस कर दिया. MRKH, MKH नहीं, MRKH. ठीक है. So MRKH can lead to direct infertility. उसको uterus ही नहीं रहेगा. So you have uterus में acquired and inherited. So उसमें inherited में were the ones that you just spoke, MRKH and septate uterus, and acquired में you have Asherman syndrome. How do you treat Asherman syndrome?
So we can have adhesiolysis and we can have some packing material so that the walls don't oppose each other. Otherwise, there can be again adhesions.
Like packing material like?
IUCD.
Okay, IUCD is one good answer. Anything else? Folies. हम लोग folies डालते हैं, pediatric folies डाल के रख देते हैं. and we start the patient on OC pills so that the uterine walls start generating the endometrium. But there is a small problem over here. The problem is whenever you have done any DNC vigorously, you have eroded not just the functional but even the basal endometrium. And if the basal endometrium is lost, then the OC pills are not going to act on this. The endometrium is never going to regenerate. Hence, the treatment for Asherman syndrome is not just adhesiolysis, but also you have to follow it with स्टेम सेल इंजेक्शंस. स्टेम सेल्स कहाँ पे मिलते हैं? अपने पीआरपी में, प्लेटलेट रिच प्लाज्मा के अंदर मिलते हैं. सो यू इंजेक्ट प्लेटलेट रिच प्लाज्मा इन द यूट्राइन वॉल्स एंड दैट विल स्टार्ट leading to proliferation of the endometrium, and hence they will grow again, and then you can start giving them OC pills, because OC pills will only act if there is basal layer of endometrium that is present. If that is also eroded, then it is never going to regenerate the endometrium. So how do I regenerate that basal layer? It is by injecting PRP or stem cells. Got it?
That's
Okay. So uterine procedure MTP नहीं, no history of infections. Which infections? PID वाले जो तूने बताए थे पहले.
PID, genital tuberculosis, like can cause obstruction of fallopian.
Fallopian tube. Okay.
Can cause.
Great. बराबर बराबर. Next slide.
Okay, this is past obstetric history.
Past obstetric history. ठीक है. मेरे को बता, if your patient would have been someone जिसके साथ first trimester abortions होते हैं and she has come to you again, fourth pregnancy with a scan of missed abortion, what would you do next?
So we can suspect of any congenital abnormality can be one reason.
Congenital abnormality is the correct term. 10 weeks.
Certainly, chromosomal abnormality.
बराबर. Chromosomal abnormality. So what will you do?
So we can do a karyotyping of both the patient and her husband.
Okay. And the biggest sample is your product. That conceptus जो missed
Placenta.
abortion में गए. नहीं,
Otherwise, the
placenta नहीं,
product,
10 weeks के नीचे. It is your product from conception,
the
जो भी है.
the expulsed material.
Yeah, the expulsed material. So you will send it for that. Now, for all the PGs और अगर UGs भी interested है तो all the recent guidelines say, एक बात याद रखो, बहुत ही इंपॉर्टेंट सी बात है ये. कैरियोटाइपिंग होता है, ठीक है. प्रॉब्लम ऐसा है that all these cells that you are sending for karyotyping, the product of conceptus, it's a dead tissue because it is missed abortion. एंड काफी बार ये मिस्ड अबॉर्शन वाले प्रोडक्ट से यू आर नॉट एबल टू कल्चर, सेल कल्चर नहीं बना पाते हो एंड कैरियोटाइपिंग फेल जाता है. फिश तो डेफिनेटली फेल जाता है फ्लोरोसेंट इन सिटू हाइब्रिडाइजेशन. इसलिए द रेकमेंडेड टेस्ट नाउ ऑन इज ऑलवेज क्रोमोसोमल माइक्रोअरे, CMA, जिसका दूसरा नाम है CGH भी बोलते हैं, जीनोमिक हाइब्रिडाइजेशन भी बोलते हैं, but the main name is chromosomal microarray. So the test of choice in today's world for anything is bare minimum of CMA. Karyotyping अभी old school थोड़ा हो गया है. फिश तो लिटरली टाइम पास हो चुका है. फिश का एक ही फायदा है कि 2 दिन में रिपोर्ट आता है. कैरियोटाइपिंग को 14 दिन लगते हैं, माइक्रो अरे को भी 14 दिन लगते हैं, 10-15 दिन आराम से लगते हैं. सो द ओनली फायदा ऑफ डूइंग अ फिश इज 2 days में रिपोर्ट मिलता है, बट इट इज वेरी इनएक्यूरेट. एंड हेंस एनी टेस्ट दैट यू डू, bare minimum do a CMA. Do not rely any longer on your karyotyping, because उसमें तुम लोग को माइक्रो डिलीशन ये सब भी दिखेंगे. जिससे डाइजॉट सिंड्रोम, you will be able to get Dijon syndrome and all these things as well. So always do CMA, chromosomal microarray, for any product of conception or for any amniocentesis, CVS testing that you're doing for any indication. Bare minimum is chromosomal microarray. If the patient is able to afford, then also do next generation sequencing, that is whole genome or whole exome sequencing. That is the best thing that you can do, but that is going to cost you around 20-25,000 minimum. So chromosomal microarray can cost you somewhere between 6-7,000. That is a good enough test. Whole genome sequencing is 15-20,000. So if a patient can afford, do both of them. Remember, next generation sequencing is not a substitute for microarray and karyotyping, because in karyotyping you're counting the total number of chromosomes, whereas in genomic next generation sequencing you're looking at individual genes. These are two different aspects. So never skip one in the favor of the other. So if you have a patient, always remember, do not throw her conceptus away. More important than parental karyotype is your products of conception, the test that you do for products of conception. So that is one investigation that you will do. Now that you have done parental karyotype, what do you expect inside it?
So there can be chromosomal abnormalities. If the maternal age is advanced, then there can be disjunction disorders, meiotic disorders like Turner syndrome. most common cause.
Turner syndrome. Will a Turner syndrome female even conceive?
No, the fetus can be paternal syndrome and lead to
Okay, in
abortion.
fetus. No, but I'm asking about the parents. Parents karyotype, what is the commonest that you will find?
Aneuploidy.
Aneuploidy, yes, very good. Which aneuploidy though? Aneuploidy is a very generic answer. Which specifically?
Trisomy 13, 16, 18.
Okay, trisomy 13, 16, 18. 13, 16, 18. Will your parent survive with trisomy 13, 18? Edward syndrome. Ever seen an adult Edward syndrome? Ever seen an adult Patau syndrome? Are they ever going to conceive?
No, no. No,
So,
only Down syndrome will means 21 trisomy.
yeah, trisomy 21. I mean, not even Down syndrome. You can look at a female with Down syndrome and then say that this woman has Down syndrome or this husband has Down syndrome. A better answer is balanced translocations. Balanced translocations mean that when you look at the couple, they are totally normal, but they have something, some problem in them which has been balanced out. That is called as balanced translocation. When two balanced translocations marry and their sperms meet, their gametes meet, the zygote and the embryo that is formed may have an unbalanced translocation, and that unbalanced is never going to survive. It will spontaneously abort. And hence, you have to look out for balanced translocation in parents. Did you understand what are you exactly looking for? Remember, if there is a person with trisomy 13, 18, 21, 13 and 18 will never survive beyond a week of their birth. And trisomy 21, you will be able to make it out by looking at them that they have something wrong with them. So you will never see these things in your patients. What you will see is going to be in the report. And these are the things that you will be seeing in the reports. Got it?
Yes,
Yes.
sir.
Okay. What is the difference between missed abortion and blighted ovum? Technically the same. A blighted ovum is basically, they say the ovum was never fertilized in first place. And missed abortion is basically when you had a pregnancy, the pregnancy is still inside, but it is not viable, but the body has still not thrown it out. That is missed pregnancy. A lot of people use blighted ovum as an alternative to missed pregnancy. It also shows that blighted ovum is not going to have any fetal or embryonal thing inside, only a G sac is going to be left inside. So that is technically a blighted ovum. Okay. Next slide.
Menstrual
Menstrual
history.
history. Okay. Menstrual history. Pe what will you get to see? Only Turners and all. Not significant. Next.
So टर्नर्स होगा तो अमेनोरिया होगा.
Amenorrhea hoga and she will never conceive. Turners will have infertility, not
Yes.
recurrent pregnancy loss. Okay. Next.
Past history. History of cervical surprise at 14
Why
days.
epilepsy?
She might be consuming some anti-epileptic drugs.
Okay. Anti-epileptic drugs. Okay. Fine. Anti-epileptic drugs. What will that lead to?
They can cause like valproate can cause neural tube defects. Phenytoin can cause fetal hydantoin syndrome,
Will that
congenital
lead to
anomalies.
recurrent pregnancy loss?
Um, Not necessarily.
Not necessarily. Exactly. All these neural tube defects, in fact, need to be aborted. If you don't abort them, if you don't do MTP, then they progress till third trimester. They don't die. They don't, in fact, even die immediately after birth. They even survive after birth. Many patients, many babies have survived several years with anencephaly. It's the wrong thing to make them survive in first place, but yes, they can survive. So no, not really. Okay. Next, no TB contact, medical illness, fine. Next slide. Dietary
Dietary
history,
history.
okay. That's absolutely okay, fine. Not a PSM person. Next.
Family
Family
history.
history. Yes, yes, correct. Tell me.
So there is no family history of recurrent abortions in mother, sister, aunts. So we can rule out some inherited disorders, congenital anomalies or connective tissue disorders like Ehlers-Danlos syndrome.
Very good, fine. Autosomal dominant होगा वो सब. Good. ठीक है. No history of
Then,
any congenital abnormalities. Okay, fine. Next slide.
no personal history. There is no history of any addiction. Smoking and alcohol consumption can cause recurrent abortions.
Can
Like if
cause
you
recurrent
continue.
pregnancy loss. Okay, fine. Next. By the way, before you proceed, for everyone, there's a feedback form that we have put in the comments. We had received 88 feedbacks last time. That's a great response. Kindly do fill the form again. It is important for your attendance and also for us to for us and for the presenters to know about how the performance was, how the discussion was, if you all liked it. So I'll ask the team to put it in the chat. Kindly fill it. Yeah, continue. Next slide.
Yeah, so then examination. The patient was examined with due consent in presence of female attendant in well-lit area. She was conscious, alert, oriented to time, place, person. Then she's average build, adequate nourishment. Weight gain is 8 kgs in pregnancy, and height is 155 centimeter with preconception BMI is 20.8. So extremes of BMI are also risk factors for recurrent pregnancy loss.
Okay.
Like less than 18 and more than 27 or 25 in Indian context.
Okay. Fine.
Then pulse vitals are stable. Then there are no scalar, icterus, clubbing, cyanosis, lymphadenopathy, or edema. Then breast is normal and pregnancy-related changes are present. Thyroid is not palpable and no eye signs of hyperthyroidism is present.
Okay.
Then
Okay.
shall I
Abdominal
continue, sir?
examination is normal. Okay. What can be abnormal in your abdominal examination, by the way, in a patient with recurrent pregnancy loss? Fetal growth restriction can occur. Fetal
Yes.
growth restriction can be common because of placental disease, Apla syndrome, definitely sickle cell disease again. Even in patients with chromosomal abnormalities or something, you can have less sympha is your fundal height, so fetal growth restriction. What else? What's next?
So then we have Leopold's maneuver. It first grip shows that the fetal buttock. Second grip shows that right side has the fetal limbs and left side has the fetal back. The third grip shows the fetal head and the head is not engaged.
Okay, fine. This is okay. This is a normal. What's next?
Then we have other systemic examination. So all of them are normal and
Everything
fetal
normal.
heart rate
Yeah.
was
Heart
120
rate is
beats per minute.
120. Okay, next.
Then we have the provisional diagnosis. 29-year-old gravida 4, abortion 3, with history of recurrent second trimester losses with no known risk factors. Uh, Presenting is a case of recurrent pregnancy loss with the differentials or etiology can be cervical incontinence, uterine abnormalities, Apla syndrome, hypothyroidism, and fibroids. Uterine
Okay.
fibroids.
Okay, fine. Apla syndrome and second trimester. Okay, fine. ठीक है. चलेगा. That is your provision. Fine. That is it then, right?
Then we have
So
like some planned
investigations. You have
investigations.
okay, fine. Nothing
And
significant. We have already discussed all this. Okay.
yes, and when we
So
have the final
your
diagnosis of
final yes in cervical insufficiency that you have, and you will. Oh, by the way, cervical insufficiency. I just read. What is worm stitch that you were talking about? How do you
worms,
take it?
like so just read the name. I don't know the exact procedure.
Okay. So there is something called as an emergency circlage. Would you want to tell something more about emergency circlage or
Yeah,
rescue
yes,
circlage?
so there is the main aim of the emergency circlage is that the membranes should not come in contact with the circlage.
Okay. So how do you ensure that?
So we can do it first. We can keep the female patient in the lithotomy position with head low position.
Okay.
Then we can use a Foley's catheter with around 30-35 ml of saline and slowly push
30,
the membranes
35 ml.
inside.
That is quite a lot. 30, 35. It will not even go inside your cervix, right? In fact, you will end up giving the female a bigger thing. 30, 35 is a lot. 20, 25 is okay. You just have to gently push it upwards, right? You don't have to show it inside. You just have to push it upwards. प्यार से. Okay.
Yeah.
What else?
Then sponge holding forceps with moistened swabs of cotton can be used to gently push the membranes into uterine cavity. Uh,
Okay.
then we can fill the bladder with normal saline, which will cause retraction of amniotic membranes into the uterus.
Okay. Fine. Okay. So when I asked you about the worm stitch, worm spelling is by the way WURM. Worm stitch is basically you take two stitches And in those two stitches, you take the first stitch between 12 to 6 o'clock and the next stitch between 3 and 9 o'clock. So you take it in a plus sign fashion, and that is just taken to temporarily buy time and keep the cervix closed. Remember, emergency cerclage has the worst efficacy, has the lowest efficacy because the cervix is already dilated and it might just give away anytime. She might start leaking, she might have PPRM at any point of time, and hence it has the worst efficacy. And these patients are preferably kept admitted because you never know when they will start leaking and will have PPROM. So, that is it from today's session. Simsog, do we have the feedback form that we can put it up? Until then, I would want to answer a few questions quickly. Everyone, whoever has any doubt, please ask me in the chat. Before coming to the chat, Parth and Mangesh, very, very well done. And that was a great Viva. I loved having this Viva. It was excellent. You prepared really, really well. And why don't you agree with consanguinity not being a risk factor? I already discussed that, Kshitij. I discussed that in length. So can you repeat the TSH range thing? Yes, I will repeat it. So in the TSH range, the normal range is going to be between zero point 0.1. Yeah. So by the way, I have put up the feedback form in the comments. Kindly fill that up. Your feedback is something that really helps us. Apart from that, see, the TSH thing is your lower normal limit is zero point 0.1, zero point 0.2, and zero point 0.3 across the three trimesters. Then these are the lower limits. The upper limit is for all women who are pregnant, 4, except in those women who have three risk factors, and those three factors are going to be your recurrent pregnancy loss, infertility, and your anti-TPO antibody positive status. In these women, you keep the upper limit at 2.5. So you treat the women between 2.5 and 4 only when any one of these three risk factors are present. That is it. There is nothing bigger than that. What are the causes for first and third trimester abortions? Samala, do you believe that we would call anything that goes to the third trimester as an abortion? That is a criminal question. That's a very bad question. And we would call it preterm labor. Why would we call it an abortion in the third trimester? Could you repeat what is OAPS? OAPS is nothing but calling a patient or treating a patient like an APLA syndrome patient with merely one single positive report of APLA. So even once if it is positive, you do not wait for the second one to be positive 12 weeks later. You just start treating them with LMWH anyway. Could you repeat about RH incompatibility and RPL? Um, Parth, could you just repeat RH incompatibility and RPL?
So in RH incompatibility, it can the first pregnancy will be delivered, but during the delivery there can be contact of maternal blood and fetal blood, and which can cause antibodies against the RH positive fetus in subsequent pregnancies. So it can cause secondary recurrent pregnancy loss.
Okay, fine, great. Apart from that, in any case, in case of RPL, if starting LMWH without any cause leads to LMWH, it is advisable to give LMWH in every subsequent pregnancy. Uh, eh, whoever is this, kindly switch off your mic, please. 88 DROH.
Oh, sorry.
So, the thing is, remember, it is a good thing to start LMWH, but affordability is a big question. And secondly, it's an anticoagulant at the end of the day. If there is any episode of subchorionic hematoma or if there is spontaneous abortion, she's going to bleed a lot. You do not want to do that. There is also a question of why do we not prefer to start progesterone in the first trimester? Now, and how early do we start aspirin? So, see, progesterone is going to help you prolong your pregnancy. It is going to help you pull your pregnancy. A lot of people start it since the day they conceive. That's a very wrong thing to do. Remember that if your fetus or your embryo is grossly abnormal, the body is going to abort it immediately. Now, you do not want to prolong a pregnancy that was abnormal by giving it progesterone. So, ideally, you start progesterone once you get your cardiac activity. Cardiac activity is only going to come once your fetus has most things correct. The best time to start progesterone is going to be after 12 weeks because till 12 weeks, most of the spontaneous abortions would have already happened and the pregnancies that will be inside would be grossly normal. They might have subtle abnormalities like Down syndrome, Patau, all these things. These are quite subtle in comparison to gross genetic defects that can occur earlier, like trisomies. Trisomies is the entire set of chromosomes are repeated in a third set. All these things can continue, which is why the ideal time is to start after 10 to 12 weeks. But it can be started before as well, but do not start it before cardiac activity is seen on a scan, because that is like prolonging a very bad quality pregnancy. Aspirin to be started 150 milligram, 75, 150, anything will do in patients with BOH. Why do we start it in patients with BOH or RPL? Is that it is an antiplatelet agent. It increases, it improves the blood supply to the placenta and to the fetus. It prevents clot platelets from plugging in. So you can start it after 12 weeks. Apart from that, any other questions? Sir, venous sinus thrombosis, if due to eclampsia, your eclampsia is never going to lead to sinus venous thrombosis. CVST, that is cerebral venous sinus thrombosis, is an independent event. It is an independent event and is not related to eclampsia. Eclampsia is a lot to do with the brain. Brain and cerebral venous sinuses are two different things. They are not the same. Apart from that, when to start aspirin, I have spoken about it. Blighted ovum, Robertsonian, basal layer, deep high vaginal swab. Apart from that, yes, then every single thing has been discussed. And that is it from this session. So thank you so much, Parth and Mangesh. It was an excellent session. Amazing. I'm really glad that you asked all this. Great question. So great answering. So yes, thank you so much for this presentation. It was a very different topic. It is not something that you will easily find in undergraduate exams, but if you do, it should not cause you a problem. Plus, you might have those instruments like Shirodkar's needle and all in your exam, which may put your questions towards cervical incompetence. So we have answered everything today. Your vivas on severe preeclampsia, preeclampsia can go towards APLA. So we have answered that as well. A lot of patients with preeclampsia in current pregnancy tend to have multiple abortions in the previous pregnancy. So that can be a problem. In that scenario, you can have questions on APLA syndrome. So that is it from today's session. Thank you so much, everyone. Thank you, SIMSOG. I hope everyone understood all these things, all the questions that we spoke about. Thank you, Parth, and thank you, Mangesh. Thank you, everyone. We'll call it a day. We'll have our next session on Saturday night, 10 p.m. Thank you so
We
much.
really thank you, sir, and SIMSOC team for giving us the opportunity to present in this session. We really enjoyed learning from you. Thanks a lot, sir. And thanks a lot to SIMSOC team.
Thank you so much. That's really sweet of you to say that. And we have posted the feedback form link in the comments. We'll also put it on the group. Um, we'll also put it on the group if required. So yeah, we have already put it. Thank you so much, everyone. We'll log out then. Thank you. Good night.
Thank you so much, sir. Thank you so much to the presenters as well. Please do ensure that you fill up the form mandatorily for the certification. Thank you so much for attending.